How do you counsel for a right arch, left ductus? Maybe Jack, you can take mine. Do you say mostly right arch, aberrant left subclavian? If you do not see another arch, will you do CT, MR imaging for all babies postnatally, even if asymptomatic?
Yeah, good question. So a couple of different aspects to that. First is how do you counsel in terms of what you're going to tell the patient at that prenatal encounter? Right arch, left duct, there was an abnormality there. The implication of the question is that, yes, sometimes we can't exactly see all the head vessels coming off. We can't necessarily rule out whether there might be an aberrant subclavian or whether there might be a vascular ring in some way. So all those patients do get plugged into a system of need for postnatal follow-up. Next question is how best to assess those patients. I think an echocardiogram is a good starting point postnatally. We often can make the call of a vascular ring simply with echo alone postnatally. If there are any issues or questions in relation to that, then a CT or an MRI would be helpful. More likely a CT because we're looking mostly for anatomy, and that's a much quicker thing to do. An MRI would likely require some sedation for that, but that's how I would think of it. The other implication of the question there also is in terms of the presence of a right arch, does that indicate the need for further evaluation in general? I think the answer is yes, and as a fetal cardiologist in which patients are referred to me, I'm making the presumption that the patient was sent to us because somebody else has done a good scan of the body and looked for other things, like a cleft lip or palate, and that's not the case and such. But I would have a dialogue with the patient and with the referring physician as to making sure that that's the situation and perhaps consider thinking about some other assessments. Non-invasive prenatal testing for sure, whether an amniocentesis or not is indicated, I think depends on what else may be present.
Thank you.
And I may have a little bit slightly different take on it. There's probably as many answers to this as there are pediatric cardiologists, but the isolated right aortic arch left ductus where we clearly see a normal innominate, so the mirror image without an aberrant left subclavian, that is not a vascular ring, and if there's no there is an entity called a circumflex right arch, which can cause some compression, but that's very unusual, and most of those patients are asymptomatic, are normal, and I would counsel them that the baby is likely to be normal. The issue of 22q11 deletion is an unknown because the denominator is not known. How many of you have a right aortic arch? Unless you've actually looked, you may have one. And so for nervous people, I would definitely say, there's no reason not to get a microarray, other than you might find some variants of uncertain significance. But specifically thinking about ruling out 22q11 deletion, talking about it, and in the end, I don't feel that strongly that they need to do it. I think right arch, left ductus, mirror image branching is most likely to be a normal person. The aberrant subclavian issue is that introduces the probability that's a vascular ring, and so the probability of some degree of compression of the trachea and esophagus that are encircled. And there's a nice series out of the UK that looked, they did bronchoscopies on all of the patients, whether they were symptomatic or not, and 70% of the patients had compression on bronchoscopy. And so I personally don't wait for symptoms. I counsel that this is a vascular ring. They will need it repaired. And in the absence of any symptoms, I will recommend elective thoracoscopic repair of that vascular ring at around age 2. And it's an overnight stay in the hospital and minimal morbidity. And so that's been my approach. But I do have pediatric cardiology colleagues who will wait until the baby is symptomatic or the child is symptomatic, even though they know there's a vascular ring. And we do CT scans because everybody wants to see postnatal imaging. I find that the prenatal imaging is better, and we have, knock on wood, not been wrong about a double aortic arch or aberrant subclavian right aortic arch. It's just so easy to see in the fetus. So CT scans for confirmation, plus or minus bronchoscopy if there's a question.
Great. There was a question on the screen about what level of pulse Doppler for the outflow tracts you consider suggestive of stenosis. Is there a cutoff that you use in gestation prenatally?
No. There are no really valid gestational age-dependent normals that I'm aware of that I would think were useful. I look for presence of laminar flow and the velocity in the MPA and the aorta to be kind of similar, but the laminar flow is really key. Certainly, if it's over 1 meter per second, it's probably abnormal. But whether 50 centimeters or 75 centimeters is normal, depending on gestational age, I would go more on whether or not it's laminar.
Yeah, agreed. If one wanted to have some sense of guideline, you really shouldn't see a velocity more than maybe something a little over 1 meter per second, certainly nothing over 1.5 meters per second. Even if it is laminar, I think a velocity of over 1.5 meters per second suggests a high cardiac output state. So you could have laminar flow, but yet have, say, anemia or some other volume load in some way that could lead to that. Typically, I like to see pulmonary artery velocities. Normally, they're going to be lower than the aortic velocity because simply the profile of the flow in the main pulmonary artery is such that because the MPA is wider and more dilated than the aorta, normally your peak velocity is going to be a little bit lower, typically under 1 meter per second. Aortas are going to be a little bit narrower vessels. The peak velocity there, laminar, will be 1 meter, rarely much more than 1 meter per second.
So, question on fetal echo surveillance becomes more detailed. What's the professional life of our sonographers with regards to development of musculoskeletal disorders? It's a very actually important question and issue because especially with diabetic moms and with obesity, a lot of those patients are getting echoes. I strongly recommend, as if you're a sonographer or if you work with sonographers, to make sure that they're practicing very ergonomically sound approaches. Always scan down, always have your elbow closer to your chest. Make sure that you rest your elbow while you scan. There are a lot of important information that are available online to help you minimize your musculoskeletal problems. But absolutely, it's an issue. If you go to the SDMS website, I think there's a big section there on how to scan ergonomically. At some point, about 8 or 9 years ago, I invited a specialist who specializes in this to work with our sonographers. She spent, I think, 3 days in the unit observing how the sonographers scan and provided very important tips for many of them, even though some senior sonographers that have been scanning with us for 20 years of how to minimize these injuries. And a membership to a spa sponsored by your director of the unit will be really helpful. Is it safe to use pulsed and colored Doppler in the first trimester? Colored Doppler has much lower energy than pulsed Doppler, so the idea is to avoid using pulsed Doppler unless it is really clinically indicated. We don't use pulsed Doppler routinely on our first trimester scan unless there is an abnormality that we are interrogating. Both the AIUM and ISWAG have very nice documents on the use of colored Doppler and pulsed Doppler in the first trimester. In general, the summary is that colored Doppler is okay as long as it's used judiciously. Pulsed Doppler should be really limited to clinical indications. Now, if you're using pulsed Doppler outside of the fetus, like you're looking at the uterine artery, that's usually acceptable because the energy is not focused on the embryo or the fetus. Will first trimester screening become the standard or only when indicated? We talked about there are guidelines for the detailed first trimester ultrasound that were initiated by the AIUM with multi-society in the US that are finalized. They have been sent out to the societies for approval. So I anticipate that we will have in the next couple of months guidelines for the detailed first trimester ultrasound. This is not cardiac, this is first trimester ultrasound. It is going to be indication-driven in the United States, even though it's routine in Europe and many other countries. In the United States, it's going to be indication-driven. So for high-risk moms, similar indications to what you do the detailed second trimester ultrasound will be in the first trimester ultrasound. We are working through the societies to come up with a new CPT code for detailed first trimester ultrasounds along the same parameters of the detailed second trimester ultrasound. That's a long process, requires a lot of work and preparation and voting by the AMA. So that's in the works, but that's about a year or two away. You mentioned yesterday to increase the wall filter, and I noticed many of your images have the wall filter set fairly high. Will this decrease the sensitivity to pick up on small VSDs, ASDs? I think you need to really, looking for VSDs primarily, you need to be as much as possible perpendicular to the ventricular septum to really improve your ability to see a VSD, to minimize the Doppler effect of the blood flow. Increasing the gain is always helpful. Remember that VSDs will have high aliasing and turbulence in them, so you'll be able to see them. You have to be careful not to increase the gain to the level that you have a lot of tissue artifact around. So it's a balance depending on the gestational age and the depth, but you should be able to see most ventricular septal defects if you are scanning with an optimal approach.
I have another comment about VSDs and the sensitivity of Doppler. So it's extremely important to watch your frame rate, because as soon as you turn the color Doppler, the frame rate goes down, and usually for the small VSDs, it could be the factor that decreases the sensitivity more than if you just adjust the wall filter high. So that's why usually adjusting the wall filter gain and size of the box and also PRF, that would altogether influence the sensitivity. And as soon as you can adjust the color so that would be the minimal drop in frame rate, this is probably the most important, adjust the setting of the wall filter.
If you're unable to complete a fetal echo in your MFM office, at one point you would refer to Pete's Cardio. I think it's a judgment call based on why you cannot see. If you cannot see because there are technical difficulties from your staff not to be able to see, then certainly referral would make sense. If you are not see because the patient has a BMI of 60 and the indication is not high enough that you suspect there's a congenital heart disease, you may want to bring the patient back. We had a meeting in 2013 of various societies looking at this specific question among many other things, like if you can't complete the anatomy, how often do you keep bringing the patient back until you surrender? So the idea is, and we put that in writing, and this was approved by multiple societies, that you bring them back in 2 to 3 weeks for another view, and if you're unable to complete the anatomy, you inform the patient of such and document that in your record, rather than keep bringing the patient back where you know it's going to become more and more difficult. I think it's a judgment call based on the indications, the reasoning behind this, and what you're trying to achieve, why you're doing the fetal echo to start with. If certainly you suspect an anomaly, I think a referral sooner than later is in the best interest of the patient.
And also in our practice, we have a rule and recommendation based on the research that we published, that if the patient's BMI at the beginning of the pregnancy is 40 or over 40, we will suggest to have a look at the anatomy in between 14 and 15 weeks using transvaginal ultrasound. And very often for those patients with morbid obesity, this is the only time and the only chance to look at the heart in sufficient quality.
So I have Jack.
One more quick comment in relation to that. It's just in relation to a patient that I just recently saw. I think the gestational age of the patient is critically important in the decision-making about bringing them back repeatedly. Because I recently saw a patient which was referred to us because of an inability to visualize the heart fully and had three previous attempts. They were at 25 weeks gestation, and it turned out to be a complex form of heart disease. The family would have terminated had we made that diagnosis before then.
Yeah, really important. And if you are faced with this situation, because sometimes we face that in our practice, there are other options outside your state you can send patients to. I mean, it's very disruptive to the family, but just remember, Like in Washington, I think they go up to 26 or 27 weeks for terminations, but there are other states you can do that. But absolutely really important, if you suspect a problem you can't see, refer early is better. There are several questions here I'm going to go through quickly. Mary, this is for you. In detransposition of the great arteries, does a VSD help in utero with hypoxia but postnatally need repair? Or does the deoxygenation mixing actually increase the progression of the staging for needing intervention sooner rather than later?
Complicated question. I'm not sure I totally know the answer for in utero, but definitely once you add a VSD, it changes the disease in a sense, because you're going to have mixing in the ventricle, and it certainly depends on how big the VSD is. So the small VSD ends up being irrelevant, and the bigger VSD, the more kind of blue and red blood is sort of mixing in the ventricles. But I think in utero, as I hope you got a taste of, there's so many variables that are changing the oxygenation at the foramen ovale level. Is open? Is it right to left? Is it left to right? It's a very dynamic structure that I think as we all look more and more at this, it changes particularly in the end of the pregnancy and may even close off. And then the ductus arteriosus has similar variability, size, direction of flow. So all of those features together kind of determine how much blue and red blood end up either in the pulmonary arteries or the aorta. My experience for VSDs as we think about delivery room stuff is that it almost, it gives you a little bit of a cushion for that hypoxia, so that if the foramen is restrictive, but you've got a big VSD, those patients don't tend to be really blue right in the delivery room. They will turn blue ultimately, and many of them need balloon septostomies, but it's, in my experience, not been as urgent a procedure. So a VSD kind of equalizes that blood flow, at least for a little bit. As far as surgery goes, it definitely changes the complexity of the operation. I think the early studies, you could see the drop-off in survival if you had a big VSD in addition to transposition. I think our surgeons are getting better and better, and I'm going to knock on wood, but we haven't lost any kids that had a VSD with transposition. But certainly, the more things that you add, like valve abnormalities, holes in the heart, the harder the surgery is and the higher the risk.
Anita, with selective laser photocoagulation therapy, how did they determine where the abnormal anastomosis is?
I had probably a picture of a placenta that I took out of the talk, but you can actually see them. So fetoscopic, SFLP, selective fetoscopic laser photocoagulation. So they can see them, and a combination of ultrasound, intraoperative ultrasound, and visualization through the laser scope is how they identify them. I breezed past the mention of the Solomon technique, which is the newest modification of laser photocoagulation for this disease, where after they've selectively obliterated the visible anastomoses, they create a line, creating a new vascular equator, essentially completely dichorionizing the placenta. So just laser, kind of connect the dots with laser, and that's been shown to decrease the risk of post-laser TAPS and recurrence of TTTS without significantly increasing the length of the time of the procedure or the complications.
Some questions also on like the difference in terms of postnatal prognosis between tetralogy and double outlet with pulmonary stenosis. I guess there's a lot of variations that goes into that.
Yeah. I mean, it depends on the genetics and other abnormalities. If tetralogy is isolated, double outlet right ventricle with normally related great vessels is isolated and they have a good neonatal repair, they're probably going to be indistinguishable from each other. But the incidence of 22q11 deletion syndromes is higher in the TETs, and the incidence of additional venous abnormalities and foregut abnormalities and branch PA stenosis is probably higher in the double outlets. And so it kind of depends, I guess, on the other things. But the lesion itself, the surgery is the same.
Jack, with single ventricle, why isn't mechanical heart an option for palliative care?
So that's somewhat of a complex question. So why isn't a
Mechanical heart
Yeah,
an option?
yeah. So the technologies are not there yet for long-term use of mechanical hearts. Mechanical circulatory support is possible and has been used in patients with single ventricle, often as a bridge to a heart transplant. Mechanical circulatory support technologies have advanced tremendously in the adult realm, such that it is referred to as a destination therapy for some patients who are not candidates for transplant, such meaning that they just end up living with that particular instrument for some period of time. But in adults, 3, 4, 5 years is deemed a huge success. Doing that in a child is not a success in any way, and in fact, just logistically can't be done because of growth characteristics and such. So the understanding in the field is not there yet to totally replace, although it's a great concept and people are thinking about it and working on it. You can't just simply replace the circulation with a mechanical device. There are technologies being developed. There's one particular individual, Mark Rodefeld, who is a surgeon out in Indianapolis, who many of us are working with, who is developing a modified right-sided mechanical pump just to provide a few millimeters of energy pressure to help generate forward flow on the right side of the heart. And theoretically, if one could implant that into the Fontan circulation, keeping the single ventricle that's there, but augmenting blood flow to the lung, one might be able to mitigate some of the complications that we're seeing. But at the moment, this is still a concept in development.
For congenital heart disease screening and routine 20-week anatomy scan, should color Doppler be included in the 4-chamber 3-vessel trachea? I would strongly recommend, if you're in this course, that means you're committed to looking at the fetal heart. We actually, as part of our routine, detailed, and basic obstetric ultrasound exam, we always turn color at the 4-chamber view, looking for regurgitations, looking at the type of blood flow, and certainly color of the outflow tract and the 3-vessel trachea view. I think it's important, it's there. It takes 2 seconds to do, and there's a lot of information could be gained from that. Comments?
Yeah, I think that certainly if you're doing a 76811 exam, putting color on when you're evaluating the heart, there's no reason not to. And it gives you so much more information. You can miss pulmonary stenosis, aortic stenosis. You can easily miss those if you don't have a color Doppler.
There was a question. Yeah, go ahead.
Just a small comment that indeed the use of color Doppler is encouraged now by the guideline from ESOG, and this guideline is under revision, and it seems that it will be required in the new guideline, at least from ESOG.
Are there machines that don't have color on it anymore? No.
No.
So color should be a standard part of our assessment.
Yeah, I mean, you're looking at blood flow, might as well put color on. There was a question about umbilical vein varix, about the criteria for diagnosis. I mentioned 2 options, a 9-millimeter cross-section or a size of the varix in relationship to the size of the umbilical vein. Frankly, I always do a subjective assessment, and I see if it's dilated, then I call it a varix, depending if there's turbulent flow. And the ones that need to be followed, you will know these are the big ones that I showed examples of. These are the 2 diagnostic criteria that have been reported in the literature that I cited to you. They're in your reference. I always use a subjective assessment in looking at that. Thank you for your attention.